Welcome to today's episode of Medically Speaking. I have two very special guests with me today to talk about oncology, which is, of course, cancer and cancer treatment. And we'll start with just some introductions. Of course, I'm Matt Logan, President and CEO of Self Regional Healthcare, and I really enjoy having some time to share with our really expert clinicians, and I'm looking forward to our conversation today. So we'll start with introductions. Dr. Yin, tell us a little bit about yourself, your background, and how did you find yourself at Self Regional Healthcare in Greenwood, South Carolina?
So I'm Ruiling Yuan, medical oncologist. Of course, when I found here, that is because I don't like cold weather. So when I trying to find a job, I actually draw a line, the south of Virginia, and going that way, I do the interview. Otherwise, on the north, I don't. So when I came here for the interview, second interview here, Dr. Sadurski, who's late always because of the patient care, and she has a lunch with me, and only 5 minutes we talked. It's sort of like click. Mm-hmm. Then it's clicked. I said, I don't do any more interview. I stayed. People always ask me, do you have a tie with this deep south in South Carolina, Greenwood? I don't. That is always, I told them, everybody, I said, I don't have families, I don't have friends just in that deep south. But now I find I'm wrong. Why I saying that? Over the time when I talk to, taking care of my patients, they are, I think that both us, them and me, we just embraced together. We just have like a family. So when I taking care of my family, sure, I'm spending more than 100% of the time taking care of my family. So yes, I do have ties. Now I'm ends up, this will be my 10 years practicing here.
That's awesome. And you tell us where you did your oncology expert training.
Actually went to, this is a long story short. Actually, I was doing stem cell research, cord blood stem cells. And I thought, well, maybe I should go back to the clinic, particularly oncology, because stem cell transplant is part of the things. So finished my residency in Georgia, Savannah, and then applied for my fellowship, which ends up to the Baylor College of Medicine, Houston, across the street with MD Anderson Cancer Center. Good part about that is we cross-train for both fellows, so we get lots of opportunities to learn from them and the research part, and them learn from us from clinical aspect.
Awesome. Very good. Dr. Sadurski, tell us a little bit about your background and how you and your family ended up in Greenwood.
So I was in Medical University of South Carolina finishing my hematology oncology fellowship. And my name is Joanna Sadurski. And finishing fellowship, I was actually got a grant for HER2 research at MUSC, and I thought I'm gonna stay there. But my second child came, and my husband was finishing training in Augusta, and he had one more year. So at that point, I felt that the best for my family would be to be closer together. So I was looking for a job close to my husband. And it turned out that at some meeting, I was talking to a drug rep, and he said, well, they're looking for somebody in Greenwood. So that's how it started, the interview, and I started working here. Initially, I worked with another group, Cancer Centers of the Carolina, starting in 2002. And I was, and then I changed to Self Regional in 2005 when they left. So initially, I you come from academic center where everything is laid out for you. You have all the specialties you can imagine, and suddenly you end up in a smaller cancer center. And at that point, we haven't even had a cancer center. We had 3 exams room on the first floor of the South Regional Old Hospital. And I was enthralled by a challenge. I thought, well, I think I can do it. and that's how it started. And the hospital, that point, committed to build a cancer center. And I think they always had the vision which the hospital, when Mr. Sell started the hospital many years ago and put the first brick, he said, I want to bring advanced care to this community closer to home. And that's what was always the vision, to build a cancer center, to bring advanced care closer to home. And I know that it's beyond Mr. Self imagination and even beyond my imagination how it has grown. Initially, I was only one, and then now we have 4 amazing oncologists, Dr. Yen, Dr. Rahal, and Dr. Johnson, and we have 2 radiation oncologists. And it always was about delivering quality care. So we always wanted to have discussions about each patient. We all follow guidelines, NCCN guidelines, and we continue to try to do the best we can.
I'll tell you one of the things that's impressed me most, and I've been at South Regional for 20 years, and seeing the development of the cancer center and how things have changed so much during that time. And I think, Joanna, you and I probably came around the same time,
Yes.
Pretty close. And I'm telling you, your both of y'all's leadership in truly developing, I think, a state-of-the-art, a model truly that is could be used anywhere in communities like ours to show what advanced cancer care is like and should be like in a community setting. I think I really give you guys and your teams the credit for where we are, but I truly think we are that. And I'm just really proud to work with you guys, and you guys do awesome work every single day. So let's just dive in a little bit. So let's talk about cancer care, some of the services we provide here that are unique perhaps to a community in rural South Carolina. And Dr. Yen, maybe you can start us off with this.
So here are the things, a lot of time when you talk about comprehensive cancer care, that is involved in a troop to work with us, including different specialties. In the rural area, it's very hard to really get building up a comprehensive cancer center. Some of the services like cardio-oncology, exercise oncology, social cycle oncology, those are the specialties only have, be available in a few academic centers, not even in widely for the just academic centers. However, our position or location is very unique. We got to really taking care of our community by trying to bring in these services. By doing so, actually, Dr. Logan, if your team, your administration is really putting support to us, that is beyond what we as a community oncologist can imagine. Because of your support, that is how your vision is aligning with our cancer care mission. That is the way to go. With this said, a few years ago, we brought cardio-oncology here. And last year, we established exercise oncology. And it's thriving. Actually, we have a poster Dr. Sadurski leading. We are going to bring to the first rural cancer conference in this country next month. That is wonderful. Obviously, there are some social psycho-oncology we always wanted to bring in. And I know Dr. Logan and you and Dr. Kuma is trying to find so hard psychiatrist, psychologist here. So I believe in the future, near future, we can have this very advanced subspecialty cancer service in our community. The rural oncology, there are, just because of population, we're facing a lot of challenges. People trust you. Why you are coming here? Why Dr. Sadurski stay here 20 years? Why Dr. Yuan stay here 10 years? If you're good enough, why not you going to big city rather than stay here? So first of all, the most important thing is establish trust. So that is working, as I just mentioned. I found out the way is if we treating each other like family, gain their trust, then bring the services locally so that patient can receive sophisticated, cutting-edge technologies at their doorsteps. And in South Carolina, we're not that good in terms of rural oncology practice. Hopefully, Dr. Sadurski and we're trying to build up under your leadership, of course, and trying to build up a model system can be adapted to other part of South Carolina. As I always say, the new data funding is 80% of physicians in this state, it's above national average, is employed. Once we get employed, we need to really work with administration as a team. When we watch out each other's back, that's how we can fly high and longer together.
100%. My philosophy is my job is to support the work you guys do. You guys are there doing this great work and bringing these great ideas and bringing that national vision of what rural oncology can be. And, I feel like my role is to not get in your way and to help you, because the ideas you guys have are awesome. And like you were just talking about, neuro-oncology, some things you wouldn't think that a community like Greenwood, South Carolina would be like a leader in stereotactic radiosurgery for patients with metastatic lesions in the brain, but we are. And it's that vision that you guys have really brought to where we are providing that advanced care right here in Greenwood that you would otherwise, say 10 years ago, have to go to Atlanta or Duke or somewhere like that to a big academic center to get, and you can get it right here now.
Exactly. Since thank you, Dr. Logan mentioned that neuro-oncology is something we are proudly doing, working with neuroscience group, Dr. Lau, Dr. Kilburn, Dr. Cole, and their colleagues. We really work together. Tumor board, as this is the second in this. There are two neuro-oncology tumor board in this South Carolina. We are one of that. That is said something because of our rural setting. And another one is in MUSC, that's it. Our patients are so lucky to enjoy the services. I might say words wrong. Not enjoy cancer is not a good thing to do. Yeah. But with all the increased incidence, 40% of the population in this country eventually will ends up one of the cancer diagnoses, including myself. We, Dr. Sadurski and we want this community, including me, if I get cancer in the future, I wanted myself to receive best care without travel. That is the period. And we have it here. And Dr. Logan, one thing I would like to say, it's not every CEO like you. I have lots of friends, peers, and acquaintance. They always, when we get together in the meeting, complains more than much about saying good thing. It's because of, I believe education, education, education. That is the key. That is how Dr. Sadurski and I, along with our team, trying to really, do best education wise so that we align with your mission. That's how we can go far. Sorry, Dr.
Very
Sadurski,
good, very
add
good.
on more.
No, absolutely. I think that's the vision that you, as a physician, decided to that. And we cannot make people who haven't had medical background make decisions for us. And you have taken a role, administrative role, which is very hard with Dr. Kumar. I think it's applauding. And as somebody said, you cannot, if you don't sit at the table, you might be on the menu. So that's why we need to get involved and we need to make sure that the medical needs, the patient's needs are being taken care of, because you cannot make decisions about patients if you don't know what's happening in the field. And that's about advocacy, about going to Washington and asking for help, asking for advanced care, asking for making sure that we don't have drug shortages, that the patients have access to care regardless of the zip code. Is it Washington or is it in South Carolina? That we have the best care. We provide the same care. We follow the same guidelines. We have access to cutting edge immunotherapy, chemotherapy. Now, is it possible that we don't have everything in here in Greenwood? Yes, there are some things which are maybe beyond our reach at this particular moment, but we cooperate very strongly with MUSC, Medical University of South Carolina. We cooperate with clinical trials. We have open clinical trials for last 25 years here at South Regional, and now MUSC has. To now, they have a designated cancer center status. Within the next 2 years, they're applying for comprehensive cancer center. And we have this access, this relationship with them. If we don't have something here, we will get it there. And that's exactly what also I was saying, that here in smaller community, we have to wear many hats. If we don't have answer for a patient, we don't say, oh no, we don't know. We research, we ask, we cooperate, we refer to other centers if we have to. Our patients have access to MD Anderson, to MUSC, to Mayo Clinic, and they getting the best care.
I think that's key. A lot of times I think people are, I'm just going to see the little local hospital, but not realizing that like behind like South Regional's Cancer Center, you have all those other resources.
Exactly.
And the trust and knowing that if someone has like an unusual cancer, something we don't see that often, that we might not be experts in, that we know who to call. And we're going to send you the best place that is. If that needs to be in Houston to MD Anderson or to Charleston to MUSC, we have those relationships that we'll send you. And the cool thing is, like, for example, someone goes to MD Anderson and they see someone and they need to be on a chemotherapy regimen for a period of time. They don't have to go to Houston to get it. They can come here to South Regional and get it in Greenwood. They'll go get that consult from that super specialist, subspecialist, and whatever type of cancer it is. And then come back here, and it's coordinated with the team here to get that cancer treatment right here closer to home.
Exactly.
It's a beautiful thing. You guys have created an amazing system.
It's a phone call away. We have a great relationship. We go to meetings. We meet doctors. We have great relationship with experts. And there is no reason not to. And sometimes patient says, well, I don't know, would you be okay if I go for a second opinion? Absolutely. You have a cancer diagnosis. It's stressful enough. Don't worry about my feelings.
Correct.
I want you to get the best care. Yep. Is it there, here? I want you to get the best care. If we can work together and you can get the treatment here closer to home, we will help. Absolutely. Yes.
Yeah. I think it's beautiful. And just that whole philosophy of it's all about that patient.
Yes.
And get each individual patient with their individual type of cancer the best treatment that is available anywhere
Exactly.
And you do it right here.
Yes.
And I say, if we don't know, we'll get you where you need to go.
So I actually, it's interesting that I recently got a text from one of my patients who was, the disease progressed May last year. And I remember he went to our clinic and everybody was crying. Everybody was coming from the CNA to nurse, and then that it's so bad. And it's a phone call, and I said, no, there is no hope. We have life. There is still hope. So we cooperated with experts. We got him on something called BITE and then additional treatment. And the patient is doing fantastic. And it's working. And it's enjoying his life. And he's traveling and having a great time and not worrying about cancer anymore. He's in complete remission. So when you go from something like this to here now, you're just like, it's incredible. It's just it's very rewarding to be oncologist now, I think.
That's awesome.
It's absolutely wonderful.
Just wanted to follow up with Dr. Sadurski said. Research is very important. That's how the cancer actually mortality dropped less than 4 million people over 30 years because of advancement of treatment. This is one thing we are trying to bring every new technology here. Example said, just Dr. Sadurski said, BITES. That is a very fancy name. And we are actually actively working with our pharmacist administration and evaluating which disease, what BITES we need to bring in hospital in community right away. This is said that we actually worked very hard, got the liquid radiation back for treating prostate cancer. It's called Pluvicto, or generic name called lutetium-177. We got the treatment therapy in-house starting last month. That is benefiting a lot of prostate cancer patients who, generally speaking, are older, frail, and not mentioning if you go other place, driving is already a limitation, a burden. And a lot of time because of medical conditions, they cannot drive further. We have the technology here, and people can enjoy this very unique techniques or liquid radiation again at home. Those are the things we are trying every day to make sure our patient actually receive the best care possible.
One of the things that I love about our cancer center is I think that you guys and the team have created a unique culture at our cancer center that it just exudes compassion when you come there. You walk in the front door and you feel it, and the team shares it, and it's maybe talk a little bit about the culture in the cancer center. One of the things that I think is so cool is when say a patient's going to be there for a period of time, getting a series of treatments, like they have the same nurse every time. You build those relationships with the team, and like you mentioned, the team like caring and like crying together. It's like they really do the patients become a part of like kind of who you are. Just talk about that for just a minute.
Yeah, so culture is really healthy here. And from physicians, medical oncologists, radiation oncologists, we accommodate each other being very flexible. Sometimes when patients come to the doors, not only need medical oncology care, but also radiation oncology, we always phone call saying, hey, patient is here. Why bring them back again? Can you squeeze your time and just see them same day? We do this all the time. This is from top physician part. Talking about a nurse nurse and MAs or every supportive care, everybody is treating really like a family. That's how the bondings, relationships. At the end of the day, my patient, I'm sure Dr. Sadurski's patient is doing same thing. They just say, well, I've been in remission for a long time. Now my cancer is coming back. I need to start treatment. Can I ask my nurse? They would call the name and say which nurse I want. They all work the best. We always accommodate that part. And add on, Dr.
Yes,
Sadurski.
absolutely. So I think that, once you enter the self-regional, you are like a team self, we are a team. So I have a story, actually, a patient has been seen every 3 months for something like anemia, I think. And then so the front staff knows her already. And then suddenly she lost her husband recently, and she was really sad. So the Mandy, she came out from the desk, and she came to her and she said, "What's wrong?" And she said, "Can I offer you something?" And she held her hand, and the patient was like, "It was what I needed at this time." And I feel like I'm part of the family. So that's exactly the support staff we have. We have everybody watching out for the patient. Sometimes you would get a phone call, a patient came, looks a little short of breath, can you get this patient sooner? Our CNA are excellent nurses, and nurses wear many hats. They are from counselors, guiding you from chemotherapy side effects, being their advocates for the patient. So they psychosocial support with, of course, we have a social worker as well. So a social worker who makes sure that the patient's life doesn't get in the way of chemotherapy. So she helps with financial toxicity. She helps with overcoming the family, different dynamics when you have a cancer. And I think so, and volunteers who, some of them are cancer survivors, they walk with our patients, providing support and providing the hours to help them to get through the treatments like somebody else maybe helped them before. And the same, I cannot not mention environmental services who make sure that our rooms are clean, which also provide a healing space for patients when you come to a nice, clean exam room and chemotherapy area. So I think everybody is pulling together. We also, Dr. Yuan knows that we have an excellent relationship with everybody in a hospital. If we need some urgent care, emergency room always says, "Hey, bring the patient here. We will take care of them." We have grown hospitalists now group in our hospital. So while we are in clinic, they help us take care of the patients in the hospital. And then, of course, as Dr. Yuan mentioned, cardio-oncology. We have actually an expert who train in oncology, chemotherapy side effects. So we are unique. When we went with Dr. Yuan for a meeting and we mentioned we do have cardio-oncology, and some of the bigger cancer centers down, they were like, "Wow, how did you do that?" So
Right.
Yeah.
Yes.
So I think we have many, many, many example stories to share. But I really wanted to share one patient story with you,
Yeah.
Dr. Logan. My patient on immunotherapy got side effects. Wife called in the morning, immediately before mid-morning, the patient was here and got everything, treatment, etc. Then the patient getting better, and then what he said, if it's not because you actually working with us so closely, I'm going to end up to ER, to the hospital. The wife actually mentioned, she said, "You know what, you take care of my husband all the time, but I was asked, how am I feeling? How am I doing? This is things ask me that said everything for this hospital." She said either the patient is in an inpatient hospital, outpatient setting, no matter is in the imaging center or different places or some specialties. People always not only taking care of patient, her husband, also take care of her. She emphasized asking me what I want, what I think. That said a lot. That's how she told me. That said something. The culture actually, not only our cancer center, but self. I think these organizations, I think this is the right culture for me personally stayed 10 years.
Well, we need another 10 to 15.
Exactly. Yes.
Yeah, that
Yeah,
is
for sure.
absolutely unique,
Yeah.
very healthy
Well, thank you.
environment.
And we put a lot of emphasis at Self Regional on trying to be that place where, you don't just get care, but you get it with compassion and love. And you guys are just like the picture of that in what you guys do in the cancer center and for the patients you guys serve. So I'm certainly grateful for you all. So let's touch on a few things, just cancer in general. So what are the common cancers that you guys see? If you had to name like the top 3 or 4 cancers that we take care of most commonly at our cancer center, what are they?
So it's
Lung cancer, breast, prostate cancer, colon cancer, bladder cancer.
It's more like for older patients after 50. Like above
Yeah.
the 50, we will see more breast and colon and testicular and melanoma. So younger patients have a little bit different. So the colon cancer is more common cause of death for patients under the age of 50. And the second cause for the men and for women is the second cause of death. Yeah, so those are the cancer. Now, the dynamics in the younger patients are a little bit different because there is 80,000 new cases a year, and they actually are growing 1 to 2% a year, the incidence. So we see more and more younger patients. We don't know exactly why younger patients have more cancer. We think, of course, it's environmental. It's maybe some preservatives, maybe plastics, microplastics are a very popular term right now. So it all needs to be studied and research how to avoid those toxins and prevent and decrease the risk of cancer in younger patients.
Yeah, boy, I've certainly read a bit about this too. The younger people, younger folks that 10, well, longer than that, maybe 10, 15 years ago, you wouldn't really think about like high risk for things. Even a few patients I've had the opportunity to take care of in the emergency department would come in with, say, abdominal pain in a 30-year-old. And I'm thinking, gosh, does this patient have appendicitis or something more common that a young person would have? And then you find like some big giant colon cancer unexpectedly on the CT scan that you got looking for something else. And it's a little shocking, frankly. And yeah. So you mentioned some of the possible reasons
Yeah,
why.
and that's why I think that really the advocacy and then more learning about younger patients and the risk of cancer, because they tend to be diagnosed later, because we don't think when you have 25-year-old patient and she says she has rectal bleeding, well, it's hemorrhoids.
Right.
So then we have to and then that's why we also decrease the age of screening for colon cancer, and it's now 45 years old. So we need to be vigilant. We need to educate the community doctors about don't disregard. Now, those patients also, when they are diagnosed with cancer, the cancer tend to be more aggressive. So they get more aggressive chemotherapy, and their dynamics are changing, because they just started a new job, they have family, the fertility, they might be infertile. So all those different things and psychosocial things need to be addressed. And then Dr. Yan yesterday, she was talking about psycho-oncology, and today, so she, fear of needles, fear of tests, test results. That's all younger patients are definitely more pronounced than in older patients.
Yeah.
So, and then the genetics, and I think Dr. Yan maybe elaborated more about genetics and genetic center.
So here is the thing: the American Cancer Institution, all the stats for 2025. What are the really leading deaths of cancer, 5 big ones. Number 1 is lung cancer, number 2, colon cancer, number 3, pancreatic cancer, number 4, breast cancer, number 5 is prostate cancer. The reason why I mention about that is how we as a cancer center, we have sophisticated thoracic cancer group. We have lung cancer tumor board. We have thoracic surgeon, particularly very good about lung cancer surgical resection part. We have a good genetic center here, knowing nationwide pancreatic cancer, that is a lot of time it might be just family related. We have those service at the doorstep again. Breast cancer, right now we are not only, Dr. Sadurski mentioned about younger patient coming here to get the cancer. We actually established high-risk breast cancer. How can we managing? How can we talk to them, trying to, educating, reduce the risk, all early detections? Boy, it's early stage cancer, the prognosis is really excellent. So we wanted to detect early. We have that. And we have a breast surgeon is coming, really good one. And we have breast imagers, they trained to read breast imagings. We have that. And, with the foundation, with everybody, we are going to have a breast center. That is so cool in the rural setting. And it touching about how the nationwide in this country, what are the leading causes of death. So we are tackling that. Prostate cancer. Now we have a specific urologist. We have a really good urologist. We have a Da Vinci, very fancy surgical equipment. We have a new technologies, Pluvicto, coming here, and we are actually this year we're going to build up GU tumor board. So with all those cancer type, no matter what is leading deaths, no matter what we doing trying to reduce the mortality, we are doing really good. I'm proud of us by doing really catching up, and if not the same, if not better, we are catching up with really academic centers.
I think so. You just were talking about tumor boards. To me, this is one of the coolest things that, I mean, a lot of places do it, but it's one of the things that I think a lot of people don't know about. So if someone is diagnosed with say, let's just use colon cancer as an example, there are a group of physician specialists sitting around a table talking about every single case of that type of cancer, or the cancer that we're dealing with specific with that problem. And you've got a surgeon there. You've got the pathologist that's looking at it, the radiologist that's looking at it, the medical oncologist, the radiation oncologist, all sitting around a table talking about that individual patient and their specific cancer, and what do we need to do to give that patient the best care, all working collaboratively as a team. And we do that for the brain type cancers, the intestinal cancer, the lung cancers, each of them with their specialized tumor boards to really make sure that every patient is getting that best level of care. To me, that's really awesome. And for a community hospital to have those resources, and then you talk about the neuro-oncology and those special subgroups that are dive into those specific cases. I mean, I don't think people realize what we do here sometimes. It's amazing.
Yeah, we also have major cancer type. We also have a nurse navigator specifically, so they are navigating. Basically, to me, layman term is this person, nurse navigator, they holding the hands, starting the diagnosis all the way during their treatment. So patients feel like safe because they do have somebody to call. That is the only phone call away. They get everything, no matter how many calls they get, the people just there. It's not a machine to answer. It's not nobody return your calls. We have people there, listen, answering, and taking care of their problems, even without being a need to see the physicians, come to the facilities. A lot of things are already taking care of that. That is a part, again, in the rural setting. That is amazing.
I think the also very cool part is that we have a tumor board also involved this genetician. So we always have they are involved and we discuss the case. They also say, hey, I think this patient needs to come for genetic testing. And that is, we do have wide no genetic center in this little town, Greenwood. I think it's we have experts. I think it's one of few, or maybe 5 of 10 experts in genomic gene sequencing here in Greenwood. So I think we just have a very good setup here. And although we are, when we think, small, I think the small is maybe our strength because we can do more together. I do. I think it's just been very rewarding to work here. You have this relationship with patient. I've been 23 years, so I know I have treated maybe patient, maybe I unfortunately, so there was a mother of somebody, and I recently saw somebody who was in a high-risk breast clinic, and I saw her mother when she had breast cancer many years ago. So, and she was like, "Oh, are you still here?" And it was just so, and I said, "Thank you for, for taking care of my mom, and thank you for being here." So it's very rewarding. You see those patients at the store, in the church. I go speak to churches as well to educate. So I think it's wonderful to have that bond in the community.
Yeah. So just to add on a little side story, I actually did not know Greenwood Genetic Center is that famous until one day my friend, very good friend who is a pediatrician specifically working on genetic disorders, he is a professor in Yale right now. He actually came to visit me. Spending long drive coming, so we hosted him and his wife. And then he said, before I leave, I needed to see Greenwood Genetic Center. I said, why? Why you need to go there? I even don't know which way to go. He said, you don't know? That is very famous. Then I know that.
Yeah, you've got Yale folks, specialists coming to South Carolina to see what we have at the Greenwood Genetic Center in Greenwood. That is amazing.
Yeah, that is amazing.
Yeah. Well, anyway, it is awesome. Not to get sidetracked, but it was interesting. When I was in medical school, I did a clerkship in Australia. And when I was over there, one of my professors in Australia was talking about some of the research done on X-linked diseases that were discovered in Greenwood, South Carolina.
Wow.
When they heard I was from Greenwood, they're like, "Holy goodness, wow, that's like world famous genetic center there."
Yeah.
It was just kind of funny.
Yeah.
It's really cool. Yeah, sometimes you don't know what you got right in your back door.
Right, exactly.
Yeah.
But yeah, so shout out to the Greenwood Genetic Center too. Okay, so let's touch on some screening for just a little bit. We talked about some of the most common cancers that we're seeing in the community. So just for anyone that might be listening to this, what are the recommendations for screening for the common cancers? You mentioned colon cancer, maybe age 45 to start with screening. But how about like lung cancer? I know we've been putting a lot of effort on that too here.
Lung cancer, good you asked. This is a state I learned. Tobacco tax is zeroist once people started smoking at age 9. Sometimes that is unbelievable. So lung screening, yes, the guideline depend upon different guidelines, but right now it's sort of like starting age
50 to 77, yes. And doctor, so then we have a lung nodule clinic. And if we find somebody abnormal lung nodule, we will refer to Dr. Goodman Lung Nodule Clinic, and they will be followed. Now, within last 2 years, we had 300 cases of lung cancer, and 50% of 50 cases, 18% of them were discovered by lung nodule, lung screening technique. So I think the way that is a life-saving procedure and definitely encouraged. So I have a patient who was 50 at the time. He went to Chicago for some meeting, and he saw a screen which said, if you are after age 50, you should have lung cancer screening if you ever smoked. So he went to local doctor, Dr. Holman, and said, hey, do you think I need to have a lung cancer screening? And he said, okay. That was 5 years ago, and he had the lung cancer. He was completely asymptomatic. He had a nodule. It was removed. Still alive and doing fairly well. So I think it's just an example of how it can be detected early.
Yeah. So lung cancer, low dose CT scan, 45-year-old colon cancer, and that's either colonoscopy or the Cologuard card, right? And then what about prostate cancer, screening for prostate cancer?
I'll let Dr. Yen.
So this is a very controversial, but generally speaking, it is recommended patient, or not patient, men age 50 and above, if their life expectancy is more than 10 years, let's say, it's always recommended to check PSA, if not every year, every other year. But this is very controversial because there is no clear guideline to say one way or another. But I have found if patient actually they advocate themselves, they wanted to get a screening, and they actually detect early stage prostate cancer, like all other cancer types is curable. They don't need to spend the rest of the time of their life thinking about, oh, I still have prostate cancer. A lot of time we even actively watching those the low risk prostate cancer. Therefore, it's all recommendation is one way, people is doing is another way. I don't think the people are actually doing very good, not only this part but also the rest of the country. Some people
The guidelines are very confusing.
Yeah, very confusing.
But I think if you had a family history, somebody with prostate cancer, I think you should advocate for yourself and ask for PSA.
Sure. I know it's on the mind of our primary care doctors too. So breast cancer, screening recommendations.
Breast cancer, okay. General population start age 40. The ASCO, American Society of Clinical Oncology, or our society, recommend every year. But then if you go different society and guidelines, it's always say if it's not every year, every other years. But I do recommend all the women, average women at age 40 starting screening mammogram. We do have a 3D mammogram. That is a very good technique detecting early breast cancer, which is excellent outcome. If catch up sooner treated, that is a life-saving. That really supposed to go. On the other hand, high risk breast cancer, that is all, starting alternating MRI with a mammogram. So high risk patient always get every 6 months, they get breast imaging. Generally speaking, mammogram starting 30 years and older. MRI starting 25 and older, if they meet the criteria for high risk. The good part about Earth, again, promoting Earth, is that when women come for the mammogram, they take questionnaires and they have the calculations, model, algorithm, immediately, even before you leave, they get you already assign you a school and they tell you, and also the little information about our high-risk breast clinic. They will get this to say, hey, your calculation risk is high. If you wanted to go talk about that, you can. That is all different. So we are doing very good.
Awesome.
Yeah, I think I mean very excited about the breast comprehensive center. I think as Greenwood as a community came together, and then they have raised a lot of money. We still are a little short, so we would love the continue the raising the money for this breast cancer center, which is very, very needed for this community. We also know that we do have excellent the mobile mammogram, which was donated by Dabo Sweeney to this community to increase the awareness among women and screening for early breast cancer. I also want to mention the foundation, which has donated money to exercise oncology. So with cardio-oncology, we improve the heart health of our community, and we even started doing the yoga classes now. And I said I might come, but Stephen said space is very limited. So we need to build it bigger.
Yeah, I got you. Yeah, so I will just mention that the Self-Regional Healthcare Foundation is raising money for some of those specific things you're talking about. The Breast Center of Excellence, I'm super excited about that. And you mentioned this summer we have a fellowship-trained breast surgeon, Dr. Purak, who's starting. And then you mix that with recently, within the last couple years, some dedicated plastic surgeons to the community that can help with the breast reconstruction piece. We have dedicated mammographers who have done subspecialty training in mammography work and do biopsies and all the work that goes around that piece on the screening part.
And I think we were the first in South Carolina who were doing the contrast mammogram.
That's exactly right.
Well.
The first in South Carolina to do contrast enhanced mammogram, which reduces the need for some of the other advanced imaging modalities like MRI.
Yes.
And so we really are building the pieces. And then the next piece is what the foundation is raising money for, is just like the building and the infrastructure and putting together like this beautiful aesthetic center for the women in the community to have screening and treatments, frankly, as much as we can in that area. So super excited about that. That's a little ways out, a little more funds to raise, but in the fall of this year, we plan on starting really diving in on some of the plans for that. So really excited about the future there.
Thank you.
Yeah.
Thank you.
Yes.
No.
Yeah.
Well, you guys are both really involved in advocacy. I thought I'd just touch on that for just a little bit, even at a national level. Can y'all share a little bit of the work that you're doing at the national level?
I'll let Dr. Yen talk about it, but
advocacy?
I do want to say that we got just motivated by you. When you took that role of administration and started working, I think that's what actually Dr. Yen said, well, we need to also advocate for our patients too, because we had some drug shortages and Dr. Yen had to replace some chemotherapy, and one patient maybe ended up with more neuropathy than expected, and she had trouble putting her little earrings in the ears, and then trouble buttoning her shirt. After that chemotherapy was the good one wasn't available, and we had to substitute with maybe inferior one at that time. So we said, well, we need to make sure that we have what we need for our patients. So Dr. Yen got involved in ASCO, and it was excellent.
Tell us what ASCO is, and then tell us what you're doing with them.
Okay. So oncology advocacy is not luxury. It is a must. Why I'm saying that, research, that is a research fund. How the health policy actually dictate what is a research fund, how much we can get. And we know that research fund and really research decrease mortality. That is very exciting in the cancer world. Additionally, we physicians spend lots of time to do the administrative work, such as prior authorization, which unfortunately nowadays is become more and more complicated, and which is not good for patient care, delayed patient care. ASCO actually had a survey back to 2022. 90 something percent of the chance delayed cares sometimes can be life death situation. Like, for example, my patient, one of those, waiting for get PET CT, he passed away. That is not acceptable in this country, with just waiting for some technology or some testing and cannot get it. That is a prior authorization. Drug shortage. A lot of time, even with IV fluid, think about that, Dr. Logan. When disaster, hurricane, Helene came, even IV fluid to get drug shortages. The way to think about that is very interested in the generic, very cheap drugs. They get shortage, just like Dr. Sadurski said. Carboplatin, very cheap, generic, but we don't get that. Policies, people always business, they want to have benefit, profit. If you don't profit, how can a good business sustain? So we are trying to advocate the health policy, at least to address drug shortage and prior authorization, and as well as research funding. I started advocacy 3 years ago. At that time, only one from South, representing the whole entire South Carolina for 2 years. And this year, Dr. Sadurski, we went together. That is the party said something. 3 of physicians went there. 2 from South. That said something.
And now the advocacy, like you just said, you're advocating for things that are big deals, like drug shortages for patients, prior authorization where care can't be given until someone off at an insurance company gives approval to get the care. And you guys are advocating, frankly, for the whole state of South Carolina, that our patients in the state of South Carolina have what they need to get the good care.
Exactly. That is from national level.
Right.
We also have a so-called grassroots initiatives, which means physicians, during their regular time, either with a virtual meeting or even go to the state capital to talk to the lawmakers about health policy at home. That is one part from national wise. This year, Dr. Sadurski and I, we both joined the South Carolina Oncology Society board. We are both board member. So from that level, state level, we are trying to continue advocacy for, again, not only for our patient, my family, and my community, but also for our state for advocacy.
We are just want to tell you, but we are hoping that maybe one is very pressing problem that when the patient changes the treatment, sometimes they have medication, very expensive medication, who they haven't used, they still have closed, but we cannot do anything with it. We have a law which says you have to discard it. Some of those oral medications for chemotherapy are $15,000. So right now in Wisconsin, they passed a law that they can use those medications for other patients. So I'm hoping that maybe one day we can pass that law in South Carolina, because it's really heartbreaking when patients bring the medication to me and say what to do, and I say, well, I just call the pharmacy and we will have to discard it. There's nothing else we can do. Right now, the law is saying that we need to discard it, so it's very heartbreaking.
Yeah.
Yeah.
So when doing advocacy, oncology is not in a vacuum. If we don't collaborate with the other such parts, then there is no way we can do a lot. On the state level, the Medicaid, Medicaid fund is a big deal. For rural oncology practice, Medicaid is essential. A lot of patients, they don't have means financially, transportation, a lot of issues. Medicaid actually is essential, is life-saving line for those patients. If we don't advocate for them, nobody will. Nobody. So that is how from state level, actually, we are joining this South Carolina Medical Association trying to address those issues. And again, there is Dr. Sadurski and I, we oftentimes write late letters to the lawmakers about those issues as well. Just to try, if we don't do that, nobody will.
That's right.
Nobody. So right now, up to this part, after my 3 years advocacy effort, I feel like, to me, advocacy is not a must for oncologists. For me, it's personal because I'm fighting for my patient,
Absolutely.
for my family, maybe one day for myself.
That's right.
But I have to say it's working because since we came back from Washington, I haven't had any prior authorization request. Everything is approved.
Maybe it's coincidence. We don't know. But no. Well, listen, you guys are awesome. What you guys are doing for the community is awesome. And honestly, for the state and the advocacy work, and you guys are really leaders in this space. And we are certainly proud to have you on the team here at South Regional, and what you guys are doing for the patients that are here and trust us to care for them. And thank you. Thank you very much for what y'all do.
Thank you. Thank you.
So with that, we'll wrap up this episode of Medically Speaking, and thank you all for tuning in today, and we'll catch you next time. Thank you.